So you open your biopsy report, right? And you're expecting answers.
Yeah, you want clarity.
Exactly. But instead, you just get this wall
Yeah.
of dense medical jargon, and one word always seems to be typed in bold, just jumping out at you. Hyperkeratosis.
Oh, it's a terrifying word to read on your own chart.
It really is. It sounds like a severe diagnosis. It sounds permanent. But what if it's actually just your body's deeply confused microscopic attempt to protect you?
Right, because when you are already navigating the discomfort and the anxiety of a sensitive medical issue, seeing this multisyllabic, alien-sounding word can send you straight into a panic.
Oh, for sure.
We naturally want our diagnoses to be clean and simple, but skin pathology, especially in the anogenital region, well, it's a really complex environment. The body's defense mechanisms often end up doing a lot more harm than good.
So, welcome to today's deep dive. We're looking at a massive stack of medical guidelines, dermatology journals, the BIHH guidelines from the UK, and various patient support resources.
A really comprehensive pile of data.
Yeah, quite the stack. And they all focus on a condition called lichen sclerosus, or LS. But our mission today is very specific. We are going to cut right through the pathology jargon to answer one crucial question.
Which is so needed.
Right. We want to know, what is the clinical significance of hyperkeratosis in a lichen sclerosus biopsy report? Like, what does that single word actually mean for your daily symptoms, the medication you're prescribed, and, your long-term health?
It's the perfect question, and if we look at the broader context of these sources, lichen sclerosus is a chronic inflammatory skin disorder. It predominantly affects the anogenital region.
It affects both men and women, right?
It does, yeah. But the data shows it occurs far more frequently in women, and it typically presents with what we call a bimodal peak.
Meaning it hits two specific age groups.
Exactly. It most often appears in prepubertal girls and then again in postmenopausal women. Now, a doctor can often recognize it visually, but a biopsy is the definitive tool to confirm it and, rule out other things.
Got it. And within that biopsy report, the presence and the degree of hyperkeratosis acts as this sort of master key.
It really does. It tells the physician exactly how entrenched the disease is, which directly dictates the intensity of your treatment plan.
Okay, so to understand how that master key works, I feel like we really need to look at the lock itself. Let's shrink this down and look through the pathologist's microscope.
Let's do it.
The sources list 4 very distinct features that tell a pathologist they are definitely looking at lichen sclerosus.
Right. They're scanning the tissue sample for a very specific chain reaction of damage. First, they look for a dense T-cell infiltrate.
Which are white blood cells, right?
Exactly. The
Yeah.
foot soldiers of your immune system, they're just swarming the area, which indicates chronic, localized inflammation. In the case of LS, which is heavily suspected to be an autoimmune condition, these T cells they've essentially gone rogue.
They're attacking you.
Yeah, they are mistakenly identifying the delicate basement membrane of your own skin as a foreign enemy, and they're launching an attack.
Which leads directly to the second feature, because that attack creates collateral damage in the dermis. That's a deeper layer of the skin.
Right.
The pathology reports call this homogenization or hyalinization of the collagen.
Which is a mouthful.
It is. But normally, collagen fibers in the dermis are organized like this flexible, woven net. They give your skin its stretch and resilience.
Like a trampoline.
Yeah, exactly like that.
Yeah.
But under the constant assault of those inflammatory T cells, that healthy collagen breaks down.
No.
It gets glued together into a stiff, pale, disorganized band. It completely loses its elasticity.
Wow. And the texts describe it as a homogeneous pale zone, right under the epidermis. And that actually brings up the third feature, which is where I got totally stuck while reading these dermatology texts.
Oh, the contradiction.
Yes. The sources state that LS causes epidermal atrophy. So the living outer layer of the skin gets incredibly thin, fragile, and wrinkled. They say it looks like cheap cellophane paper.
But then we hit the fourth feature, which is hyperkeratosis. And the medical definition of hyperkeratosis is literally a thickening of the outermost layer of the skin.
It sounds impossible.
Yeah. Wait, how can the skin be simultaneously wasting away into paper-thin cellophane, but also thickening into a dense plaque? It makes no sense.
It's the central paradox of the disease, honestly. But it resolves when we break the skin down into its specific layers.
Okay, walk me through it.
So the epidermis isn't just one uniform block of tissue. The living layers of the epidermis, the cells that are actively dividing and holding your skin's structural integrity together, those are the ones suffering from atrophy.
Because they're being starved and damaged by the inflammation below.
Exactly. Normally, the boundary between that living epidermis and the deeper dermis looks like a weighty line. These downward finger-like projections are called rete ridges.
I think of them like the bumps on a cardboard egg carton, right? Locking the top and bottom halves tightly together so they don't just slide around.
That is a perfect analogy. And in lichen sclerosus, those rete ridges are completely flattened out or even destroyed. The living foundation is essentially crumbling.
Right.
But sitting on top of those living cells is the stratum corneum. This is the very outermost barrier of your skin, and it's made entirely of dead skin cells packed tightly with a tough, rigid protein called keratin.
Oh.
So hyperkeratosis is the abnormal buildup and thickening of that specific dead layer.
So if I'm getting this, the living foundation of the skin is crumbling and losing its structural grip, while the dead, keratinized roof sitting on top of it is just piling up thicker and heavier.
You've got it. The body senses that the underlying tissue is under attack and failing, so it frantically overproduces this dead keratin armor to try and protect the area.
Wow.
Pathologists actually use a visual shorthand for this structural mismatch on low-power magnification. They call it the red, white, and blue pattern.
Right, I saw that. The hyperkeratotic dead layer stains red, the sclerotic glued-together collagen in the middle stains white, and that underlying swarm of attacking T cells stains blue.
Yeah, it creates a very distinct, almost patriotic-looking microscopic slide. But the physical reality of that mismatch is what drives the severe symptoms that patients actually experience.
Let's talk about that, because when we move away from the microscope and look at how this actually manifests on a patient's body, that thick red zone of hyperkeratosis translates into these distinct white, porcelain-like plaques on the vulva.
Often described as ivory white in the literature, and that's because the optical density of that packed keratin reflects light differently than healthy tissue does.
So it literally changes the color.
Right. The thicker that dead keratin layer gets, meaning the more severe the hyperkeratosis, the more distinct and opaque that white plaque appears to the naked eye.
And these rigid plaques, they're the catalyst for the most notorious symptom mentioned across like all the patient support resources.
Iritis.
Yes, the severe itching. It's described as an itch so deep and intense that it wakes people up from a dead sleep.
It's agonizing. The nerve endings are surrounded by this localized inflammation, so they're constantly firing off signals. And that leads to a devastating compounding problem, the itch-scratch cycle.
Which makes sense. If you itch, you scratch.
Exactly. When a patient experiences chronic, intractable itching, the neurological drive to scratch is virtually impossible to ignore. But that chronic mechanical scratching damages the tissue even further.
Oh, no.
Yeah, it leads to a secondary superimposed condition called lichen simplex chronicus.
So that's the body's reaction to the constant mechanical trauma. It senses the scratching as an attack from the outside, layered right on top of the autoimmune attack from the inside.
Exactly. The skin reacts to the friction by ramping up keratin production even more, so the tissue becomes increasingly thickened, leathery, and scaly.
You have the underlying autoimmune disease creating a baseline of hyperkeratosis, and then the mechanical trauma of scratching aggressively multiplying it.
It's a vicious cycle.
I was really trying to find a way to conceptualize what this actually feels like for the patient, and it reminds me of a heavily calloused heel.
Oh, that's interesting.
Like if you wear stiff shoes that constantly rub, the friction forces your skin to build a thick, hard callus of dead keratin to field the soft tissue underneath, right?
It does, yeah. But the critical difference here is the structural integrity of the tissue beneath the callus. On your foot, the living skin underneath the callus is healthy and robust.
Right, it's strong.
But in lichen sclerosus, the living skin underneath that thick white armor is severely atrophied. It has lost its ridges, its elasticity, and its strength.
Oh, I see. So when the surrounding tissue needs to stretch, whether that's from simple daily movement, going to the bathroom, or during sexual intimacy, that thick black of hyperkeratosis is completely inflexible.
It can't stretch at all.
So the delicate atrophied skin underneath simply tears.
Yes. It creates deep, painful fissures. And because the underlying tissue is already compromised by the autoimmune inflammation, those fissures are incredibly slow to heal and just agonizingly painful.
So the armor built to protect the skin ends up causing its mechanical failure. That is so tragic.
It really is. which forces us to look at how this is treated. When the skin is splitting open and causing that level of excruciating pain, a standard over-the-counter hydrocortisone cream isn't going to do anything.
Not a chance. The medication has to somehow get through that dense keratin armor just to stop the autoimmune attack happening underneath it.
Exactly, and this is why the degree of hyperkeratosis noted on the biopsy is the direct roadmap for the prescription. The physical barrier dictates the sheer potency of the medication required.
So what's the standard?
The gold standard treatment for LS is topical corticosteroids, which are designed to suppress that localized immune response and shut down those rogue T cells.
It's like trying to water the roots of a plant through a 2-inch layer of dry, compacted mulch.
That's a great way to put it.
If you just use a gentle sprinkle from a watering can, the water just sits on top of the mulch.
And just evaporates. The medicine never reaches the dermis where the active disease is ravaging the tissue. That's why the medical guidelines universally dictate starting immediately with a super potent topical corticosteroid for severely hyperkeratotic disease.
For potent.
Yes, we are looking at specific formulations like clobetasol propionate 0.05% ointment or betamethasone dipropionate 0.05%.
I noticed in the patient support resources, a lot of people are terrified of these specific superpotent steroids.
Yes, steroid phobia is very real.
There's this widespread fear, often based on general medical advice, that strong steroids actually cause skin thinning and atrophy.
And this raises a massive barrier to patient adherence. It's a profound misunderstanding of how the medication interacts with this specific disease.
Can you clarify that?
Sure. It is true that on healthy, normal skin, chronic use of superpotent steroids can cause thinning. But in the context of lichen sclerosus, the disease itself is what is destroying the living skin and causing the atrophy.
Ah, okay. So the steroid isn't causing the thinning, it's stopping the immune cells that are causing the thinning.
Precisely. By suppressing the inflammation, the superpotent steroid actually gives the living epidermis the breathing room it needs to heal, regenerate those root ridges, and rebuild its structural integrity.
So how do you use it?
The standard regimen is to apply the super potent ointment twice daily to drive that heavy-hitting medicine right through the thick keratin roof. Once the intense itching ceases, which is usually within 1 to 2 weeks, the patient tapers down the frequency.
Okay, but I was reading through the BASHH guidelines, and I noticed they bring out some pretty intense secondary options if those steroids fail.
They do have backups.
Like if the hyperkeratosis is so severe, so thick and stubborn, that even clobetasol can't penetrate it. They mentioned physically breaking down the barrier with ablative lasers.
Yeah, it's an advanced intervention known as laser-assisted drug delivery.
That sounds intense.
Well, the dermatologist isn't using the laser to burn away the disease itself. They are using it to ablate or vaporize microscopic channels through that impenetrable dead keratin layer.
Like drilling tiny holes.
Exactly. By drilling these tiny physical holes through the armor, they create direct pathways for the topical steroids to finally soak down into the living tissue below.
Wow. The sources also mention intralesional injections as another backup plan.
Right. If topicals just cannot penetrate the plaque, a specialist can use a needle to bypass the stratum corneum entirely, injecting the corticosteroid directly into the inflamed dermis.
It's going right to the source.
Yeah. There is also the option of oral retinoids, which are systemic medications derived from vitamin A. They work from the inside out to alter cellular turnover and chemically reduce the hyperkeratosis.
But the literature includes massive red box warnings for those retinoids.
They do. They are severely teratogenic, meaning they cause catastrophic birth defects. So they require strict, monitored pregnancy prevention and are generally reserved for highly refractory cases, usually managed by very experienced dermatologists.
Okay, so breaking through that barrier and managing the painful symptoms is clearly the immediate hurdle.
Yes, symptom control is step one.
But as we comb through these guidelines, it becomes clear that hyperkeratosis isn't just a physical obstacle for medication. It is a lifelong red flag.
It really is.
We have to look at the cancer connection here. Because while lichen sclerosus itself is not cancer, and it is absolutely not contagious, the data shows that women with vulvar LS carry a documented lifetime risk of developing squamous cell carcinoma, or SCC.
Yes. The statistics across the literature generally place this lifetime risk between 2 to 6%.
And some specific cohorts show up to 7%.
Yeah, up to 7%. And there's also the risk of developing a precursor condition known as differentiated vulvar intraepithelial neoplasia, or DVN.
Okay, this is where understanding the cellular mechanics becomes so important for you as a patient. Why does a chronic inflammatory skin condition eventually lead to cancer?
It comes down to the chaotic environment of constant tissue damage and frantic repair. Because the skin is continuously being attacked by the immune system and then tearing due to those inflexible hyperkeratotic plaques, the cells are forced into rapid, constant replication.
Just desperately trying to patch the fissures.
Exactly. And whenever cells replicate that quickly under inflammatory stress, typos in the DNA can occur.
Right. And usually our bodies have proofreaders to catch those typos.
We do. We have tumor suppressor genes like the p53 gene. They identify mutated cells and force them to self-destruct before they can turn into tumors. But the chronic, severe oxidative stress of unmanaged lichen sclerosus can actually alter and disable those tumor suppressor genes.
So the proofreader is offline.
Yes. And once the proofreader is offline, those mutated atypical DVM cells can proliferate and eventually invade the deeper tissues as squamous cell carcinoma. So how does a patient know the difference between a standard hyperkeratotic plaque and a dangerous mutation? Because the presence of white plaques initially is just, well, it's the standard presentation of the disease.
That's the million-dollar question. And the medical guidelines establish a very strict rule for ongoing surveillance.
What's the rule?
Any persistent hyperkeratotic skin thickening, any raised nodule, or any ulcer that does not resolve promptly after an adequate trial of super potent topical steroids must be biopsied again.
So if you are adhering to your clobetasol regimen and the general inflammation is calming down, but there is one specific stubborn, thick white patch that just ignores the medication.
Or if it begins to change in texture.
Right, that is the red flag.
Exactly. A hyperkeratotic area that refuses to respond to high-potency immune suppression is signaling that the cells in that specific location may no longer be just inflamed. They might have changed their fundamental programming. Okay, hearing a 6% cancer risk is terrifying. But the sources we are analyzing highlight an incredibly empowering counter-statistic. That risk is overwhelmingly driven by untreated or undertreated patients, right?
Absolutely. When we look at large, prospective, long-term studies of LS patients, the narrative flips entirely.
Oh, so?
Adequate, lifelong maintenance treatment with topical steroids drastically alters the biological environment. The goal of maintenance therapy isn't just to stop the itching.
It's more than symptom relief.
Yes. It is to titrate the steroid use, adjusting the frequency to keep the skin objectively visually normal and keep that hyperkeratotic whiteness completely at bay.
And when patients maintain that baseline,
the incidence of malignant transformation drops to near zero?
Near zero.
Wow.
Incredible, right.
The BSH guidelines suggest aiming for a total usage of about 30 to 60 grams of super potent ointment annually for this maintenance phase.
Which is very little.
Yeah, that roughly translates to just 1 or 2 standard tubes of medication lasting the entire year, applied perhaps once or twice a week. That small, consistent suppression prevents the immune system from launching new attacks. It prevents the hyperkeratosis from rebuilding, and it shuts down the chaotic cellular turnover that leads to DNA mutations.
So if you are listening to this and looking at that biopsy report, we really want you to realize that hyperkeratosis isn't a permanent life sentence of confusion.
No, not at all.
It is a highly specific physical reality. It's the buildup of your skin's dead outer layer as a panicked response to inflammation. It is the exact reason your doctor is prescribing heavy-hitting super-potent steroids instead of just mild creams.
You need the pharmacological heavy machinery to drill through that armor.
Exactly. And most importantly, those thick white plaques are the visual markers that you can actively monitor.
Understanding this transforms you from a passive recipient of medical instructions into an active, informed participant in your own lifelong surveillance.
You know why the medication needs to be strong.
You understand the importance of adherence even when the itching stops.
And you know exactly what stubborn visual changes require a call to your dermatologist.
Exactly.
As we wrap up this deep dive, there is one final provocative thought from the research to mull over. The exact root cause of lichen sclerosus still remains a medical enigma.
It does. The literature points to autoantibodies and oxidative stress, but the initial trigger is totally unknown.
But think about hyperkeratosis not just as a clinical symptom, but as your body's tragic, deeply confused attempt to save you. Your immune system mistakes the foundation of your skin for a threat and attacks it.
And your skin, sensing this profound structural failure, responds the only way it knows how.
Right, by frantically constructing a hardened, dead fortress of keratin to shield itself from further harm.
It builds a fortress so thick and impenetrable that it eventually blocks the very medicine trying to soak in and rescue it. It's a microscopic miscommunication that ends up trapping the enemy inside the walls.
But now that you understand the mechanics of this miscommunication, you have the power to interrupt it.
Mm.
You know that with the right medical guidance, the right adherence to your treatment, and the right steroid potency, you can break through that roof
You can calm the confused immune system.
and allow your skin to rebuild its foundation.
Yeah.
Don't let the medical jargon intimidate you. Understanding hyperkeratosis is your blueprint for taking your health back.